Hey everyone, welcome to the Mettle podcast. My name is Eric Norman, and I'm a physical therapist. And shortly, we'll be joined by my colleague and friend Christian Jorns, who is also a physical therapist. And today, we're going to be talking about scope of practice and all things that kind of go into that. And so, the importance of what we do as physical therapists and how we collaborate with other health professionals as well to keep individuals safe and healthy and return to what they want to do. So, hopefully, you find this podcast enjoyable. I know Christian and I had a lot of fun recording it and discussing a topic that probably doesn't really get talked about a whole lot. So I think it's a good one. As always, if you have any questions or you have other ideas for podcasts for us, whatever it might be, please feel free to reach out. You can find us on social media or our website, flexmettle.com. And hope you have a good day. Thanks. Bye. Hey, Christian. What's going on, man?
Good morning, Eric. Things are pretty good over here. Just enjoying a nice fall morning. It was like 40 degrees this morning already. I fired up the wood stove last night. And there's nothing better than a good wood stove fire. It feels so good.
Nice. You got that sweater on,
Dude,
too? That looks like such a fall sweater.
Yeah, you're in a freaking t-shirt. Like, what's going on?
It is, let's see, what is it, 50, excuse me, one of us, wait for the weather to load, 60. It's 60 degrees out here right now.
It's a scorcher by you.
I know, I'm trying my hardest not to let the cold, I'm trying to keep this summer mentality as long as I can until it really gets to be cold up here. And I have to start wearing sweaters as well. But yeah. No, we've been lucky though. We've been lucky. Speaking of weather, it's been a really nice fall here. It's been good for like running. It's been really nice to wake up in the morning and it's like a crisp, 50 degrees. To me, that's like perfect running weather where you run and you don't get super sweaty and it's nice and cool. But yeah, so I guess there's my training update for you. I've been staying somewhat consistent with my running, and now my hips aren't hurting as much as the first couple of runs. So we're on to something.
That's good. Yeah, I've been running a little bit less than I probably should be, just because I've been focusing on this Olympic weightlifting, and it's still going pretty well. I think like the last couple of weeks, it's felt like you ever like throw a ball with your opposite hand and just like doesn't do what you want it to do? That's kind of what it felt like. But now I feel like I've got the ball back in my main hand, and so things are like moving with the bar much better. And then the only other thing I'd say about that is I bought a new barbell. Yeah.
Oh, I was going to ask you about that. Yeah.
So like for my whole lifting career, I've only ever used a power bar, like the Texas power bar. And then 3 years ago, I bought the Rogue Ohio power bar. And I've been doing my Olympic lifts with a power bar, which isn't great because it's much bigger. It's much more harsh on your hands. Doesn't really have any bend to it. So it just doesn't feel as good when you spin the bar overhead. But yeah, so I bought an entry-level weightlifting bar from Rep Fitness. I bought their Teton bar, and it is sick. It's like night and day difference, honestly.
There you go. Awesome. Now you're just throwing up heavy numbers.
Yeah, of course. Yeah.
Now you're just getting into that.
Relative to what a toddler can lift, yeah.
Yeah. There you go. Speaking of that, I guess I got one more bit is the gym I go to, they do like a monthly challenge for like their members. And so like the other last month was like how many reps can you do of like bicep curls using a 45-pound barbell in like 2 minutes. Admittedly, I didn't do that one, but so I couldn't tell you what I got. But this month we're doing basically like your max numbers from deadlift, back squat, and bench press. So I'm gonna try that out at the end of the month, I think, and see what my numbers are. I'm like, I can get into the 1,000-pound club. My legs can carry me, but deep down, I know damn well I'm not getting anywhere near the 1,000-pound club.
No, not right now.
But for now, I'm gonna keep thinking I am until I do it, and then I'll be like, shoot, it wasn't even close. But so yeah, at some point, hopefully I'll have some fun numbers to talk about there and use that as a good baseline going forward, right? Get a new 1 rep max for those and go forward from there.
Just enjoying the process. It's all it's about.
Heck yeah. So, all right. Well, like we talked about, or like I talked about in the intro, today we're going to do a little bit different style of a podcast. Christian and I, we're going to talk about introduce maybe like a new little segment here of like patient questions that we got asked during the week. And, I think it's a practical way of talking about what we do as physical therapists in terms of we answer a lot of questions, which we love, to educate and whatnot. And, this week, like I told Christian, I got a lot of like anatomy questions. I think people are just kind of curious about like, what is this and where's this at and how is that set up? And, so we're going to talk about some patient questions. And then after that, we're going to get into our kind of main topic, which is scope of practice for this podcast, both as PTs and also maybe discussing some other professions outside of physical therapy as well and how everything kind of comes into play. So anyway, without further ado, first patient question. I have a patient who is coming along pretty nicely with her shoulder rehab, but now that we're progressing heavier weight, like right in between her shoulder blade and that like upper T-spine, she's getting some tightness in there as we're progressing more weight overhead. And I kind of mentioned like a muscle. I said, oh yeah, that's kind of where, this certain muscle is. I mentioned kind of like the middle and low trap muscle fibers. And she's like, so that's where my pain is. Like, that's what's causing that discomfort. I'm like, well, there's other muscles in that area too. So I think this is a good one to get into in terms of just the anatomy of some of those muscles, and not to get too into the details, but we start out with these, like I said, these trap muscles. So like the middle and lower trapezius. And then we have like layers. Think of the body and when we think of muscles as like layers. So and then if you go a layer deeper, we're actually looking at muscles that's called our rhomboids in that same region. And then so those rhomboids, they have kind of similar action as the traps in some sense, but they're kind of oriented just a little bit differently, where they have a little bit different action on that shoulder blade. And then below that, we have what's called our paraspinals. And our paraspinals are these kind of smaller muscles that run up the spine in different segments. So I guess the take-home message is, yes, it could be maybe a trap muscle, or it could be rhomboid, or it could be, paraspinals, or it could be something else. But I think it was just kind of interesting to talk about the different layers, and her mind was a little bit blown. She was like, I didn't realize that my body or like my muscles had layers to them when it comes to the anatomy. And I was like, yeah, that's kind of everywhere. Everywhere in the body's got some different.
Yeah, I think that brings up a common question that we get asked, which is like, what is causing my pain? It hurts right here. What is that? And I'm like, look, to your layers point, there's so much stuff there. You have like 3 or 4 layers of muscle, then you have all the different ligaments around your spine itself, then you have the joint structures as well. So like there's so many different things that could be causing your pain, because every single one of those structures has nerve endings going to it, and it has danger detectors and just different types of receptors in there, and all that stuff can contribute. So like, do we know what it is? Not really. Like, we can take a pretty good guess. Do I humor patients and say it's this one thing sometimes? Yes, just because I want that conversation to move on, because it's not that important. Like, it's not that I don't like the question. It's just the more you focus on that, the less you're going to get done.
Yeah, I agree. Yep, I agree. And so, so anyways, that's the first patient question. The second one that I had this week that I thought was also interesting was another anatomy one. And this individual, we were talking about, they have hip pain, and they're kind of asking, forget the exact question, but it was basically like, is rehabbing the hip hard? And I kind of mentioned to him like, well, I'm like, it can be a little tricky. The hip is a ball and socket joint, just like the shoulder. And there's just a lot of stuff going on around the hip in terms of muscles, ligaments. And then I mentioned to him, we have a lot of nerves that go around there, especially on the back side from the low back. And they're like, oh, is that, that one nerve, like with sciatica, goes back there. I'm like, well, yes, but also we have a lot of other nerves. And they're kind of like, oh, like, what do you mean? And so just as a quick crash course, I discussed how, well, we have, starting at the spine, we have what's called different nerve roots. And these nerve roots come out of the spinal column, and then they merge together to form these big nerves, like our sciatic nerve. And then as that nerve travels down the back of the hip and into the leg, we have different kind of branches that come out of that nerve that go to different parts of the hip and the leg, etc. I don't know if you think about this, Christian, but I think about like whenever I look at a tree, right? You look at a tree and you have like the big trunk, like that's like the big sciatic nerve. And then you have these bigger branches that come out, and those are just different bigger nerves going to different parts. And then you get all the way to the end of that tree and you have these smaller branches at the very top. That's kind of like when you get all the way down to the foot, right? You have these tiny little nerves at the end of the foot. So yeah, so whenever I look at a tree, I think about nerves and kind of how they break off and travel. And so that's kind of how I explained to this patient about just a very basic nerve anatomy around that low back into the hip and the leg. And I think they took away a new appreciation of like, holy cow, there's a lot going on in the hip and surroundings.
There's so much going on. I'm glad you brought up the tree metaphor because I use the exact same
Yeah,
one.
perfect.
And I use it in that context, but also in a different one where when people have referred pain, like so let's say they have that nerve root is irritated in their spine because of a disc herniation. You can get pain going from that trunk, which is that nerve root, throughout all the branches, which is going down your leg. And that pain can spread all over. The problem might be at your spine, but you're going to feel that pain all over that leg, kind of like the symptom of sciatica. But also what can happen is that's a two-way street where you can have nerve compression somewhere in those branches or down that leg, and you can begin to feel the pain higher up. Maybe like if the nerve compression is happening in your thigh, you can feel it in your hip. And that's just because those nerves are one giant cell. And so they just communicate within itself plus its neighbors, and you can get a lot of different mixed results and mixed feelings there, which we often feel as like spreading pain or referred pain.
Yep, absolutely. Yeah, so anyways, those are my two patient questions for the week. And looking at the time here, we're already over 12 minutes into this thing, and I know we have a lot to get to with the scope of practice, so it might be best if we just kind of jump into that. I know, Christian, you mentioned that you had some stuff that you had you went to a presentation last year at the CSM conference, or it's called the Combined Sections Meetings for the APTA, our governing body. And so, or I should say our association. And so I think it'd be awesome if you could just start us off with this scope of practice discussion based on what you were talking about earlier with some different aspects you learned at that conference.
Yeah, so like the Combined Sections meeting is just a big gathering of very cool researchers and really cool clinicians that do big presentations on physical therapy stuff. And there's like stuff for every part of your body, everything you can imagine. But at this most recent one, I was interested in like bigger picture items for physical therapists, like how they could function as primary care providers, physical therapists and management and all that kind of stuff. And so that led me to a presentation on what it looks like to have physical therapists be primary care providers, meaning like they see the people first. You don't go to your PCP, you don't go to the ER, you go to your PT first, namely for musculoskeletal issues like shoulder pain, low back pain, that kind of stuff. And I learned a lot from just how to generally think about our profession and in our scope of practice within the context of physicians and chiropractors and just everything else you can imagine. And one of the things that I wanted to start with when talking about this information was just like, what is rehabilitation? And like, why are physical therapists considered rehabilitation experts? I don't have like a research quote on what rehabilitation is, but I like to think of it as helping people out of a painful situation using conservative measures, meaning like we're not going into your body with surgical tools. Okay, we're doing all this stuff from the outside. That's like through your body and through your brain. And in this presentation, they broke up rehabilitation and in particular physical therapy and how we provide care into four major categories. So like this is like broad strokes. This is what a physical therapist does in general. So the four things were, number one, education and communication. Number two, we help people learn self-management strategies. Number three, we do manual therapy or hands-on techniques. And number 4, we do movement and exercise guidance or coaching. Now, you put all 4 of those together at relatively different amounts for different people. That's basically what physical therapy does. But within each of those 4 domains, there's a lot of overlap with other professionals. And I figure we'll be talking about that a bit next. So, particularly manual therapy, that's a big one that there's a lot of overlap between the scope of practice for different providers. So, massage therapists, they can do a lot of the stuff that we can do. Almost all of it, I believe. I think the only one that they can't do is dry needling. Is that correct, Eric?
I believe so, yeah. And I was just going to make a point to the manual therapy part. In PT school, we had a massage therapist come in for 2 days and teach us soft tissue massage. And so, I mean, that's just to further your point, the kind of maybe the so-called expert in soft tissue massage therapist came in and taught us for 2 days on how to do different techniques for massage, for like soft tissue work. To my knowledge, PTs, chiropractors, OTs, ATs, and physician's assistants, those are the 5 that at least I've known to get certified.
Yeah, and of course, physicians can do it too. They just tend to not learn those techniques.
Yeah.
And then, yeah, another big one is adjustments or manipulations, where people generally think of chiropractors as being the ones that do all that stuff. Physical therapists can do all of the same adjustments that a chiropractor can do, and a lot of us do learn it. I would say when I say a lot of us, it's like relatively speaking in the profession, I would say it's not that many in the entire profession, but there are like still a large number of us. Pretty much any clinic you go to is going to have one person who can do adjustments. And I'm one of those people who do spinal adjustments, for example. So like, yeah, neck to low back.
There you go.
Moving on to that 4th category, the movement and exercise guidance. This one's all over the place. You've got personal trainers, you got strength and conditioning coaches, you have physical therapists, chiropractors. We all can prescribe or recommend exercise. Now, there is a difference though in the people that we work with and who we can prescribe, or I guess we should say who we should be prescribing exercise to. When someone has an injury or a history of an injury, and you want to make sure that you are, as the patient, stacking the deck in your favor as to getting the best results, chances are you're going to get the best results if you start your exercise plan with a physical therapist or with a chiropractor who's skilled in exercise therapy, just because we know about those injuries and we're legally able to treat people that have had those conditions or currently are dealing with those things.
And I think the other big thing too, like when it comes to therapeutic exercise, is there is a reason. You mentioned education early on, and like there's some discussion around should physical therapists have went up to doctorate level, or should they have just stayed masters? And despite on what side you take on that, I mean, there is something to be said for, and I'm not trying to sound like a cocky asshole here, but I mean, there is something to be said for spending 7 years in school and then also studying, 2 years after to obtain something like a orthopedic, like your OCS or your sports equivalent of that, or, whatever that might be. Not only that too, but also we have very vigorous, at least in some states. I know Maine is a little bit different, but at least here in Minnesota, we have pretty vigorous standards you have to keep up on with your continuing education, to maintain your licensure in those states. So I guess my point is that we have it as physical therapists, just talking specifically, a certain level of knowledge when it comes to not only the human body, but also components of rehab that we have to take into account. And this isn't even touching like the post-operative side of things, right? This is the, someone comes in with their hamstrings feeling kind of tight and they want some rehab on it. I think that as PTs, we have a certain level of responsibility to educate our patients on this topic as well, that once we start someone in a plan of care, things like manual therapy, therapeutic exercise, etc., those things are put there for a specific reason. And it even states in our practice act that not even like physical therapist assistants are supposed to change the plan of care of the course of what you're taking with that patient. Only the overseeing physical therapist should be doing that. And so, once we start talking about, well, these different lines of being crossed with manual therapy, therapeutic exercise, etc., I think it's really important for people to know that, physical therapists are the movement slash rehab experts, in that it's a very important thing to stay safe, to work with their plan of care. And if another professional wants to alter that plan of care, well, then we should be having a discussion via professions versus altering it, I guess, blindly. And so I think that's a very important thing when you want to deviate between, well, lines are being crossed somewhat within the manual therapy space, therapeutic exercise space, etc. But once you start a legal plan of care with someone, and then that's when you start to get into the whole legality piece of, well, they're currently under the physical therapist's plan of care, and the only person that should be altering that is the person that's overseeing that, hence the physical therapist that, did the examination, wrote up the plan of care, etc. And if there's other healthcare professionals that want to tell you to do something differently, or other professionals in general, as a patient, we should advocate for ourselves and say, well, before I do anything, can you talk to the PT that I'm seeing so that you two can have a discussion about what's best going forward versus changing it without that. I think that's a really important, I guess, piece here, because you're right, Christian. There is a lot of overlap within these 4 different areas.
Yeah, so going back to one of your thoughts earlier about how like PTs go into school and get their doctorate and all that, it's like even if you don't really agree with us needing to go to school that long and being a doctorate, and you kind of like you're suspicious about whether we know what we're doing or not, it's also just think about it from the experience level. We do this every single day. We have tens, sometimes 20 patients on our schedule a day who need exercise coaching and guidance. And so whether you care about the degree or not, we are getting the reps in. So we do this all the time. So purely from an experiential standpoint, we see this so much.
Yeah. Yeah, no, I couldn't agree more. And I think I think that's something that can get lost sometimes, in terms of just like, oh man, I'm trying not to get heated right now because we're of of people thinking like, oh, they're just like glorified, personal trainers or whatever kind of BS you want to talk about there. But I just think it's like, yeah, we deal with these things a lot every single day, like you said, and just the experience alone being put into it. I put out a video the other day about, shoulder pain and shoulder rehab, and I just kind of discussed like how these things seem to benefit my patients the most. So here they are, right? I didn't really get into the research behind it. It was just based off my experience. People do really well with these. Um, but yeah, no, I think that's a really good discussion to be had in terms of, manual therapy, therapeutic exercise. Now, don't get me wrong. If, let's say you had a hard workout a couple days ago and you have some pretty serious muscle soreness 48 hours after, and you know that it's not an injury, you know that you didn't damage anything, it's just this muscle soreness, and you're working with your personal trainer or a strength coach or someone, or even like some other healthcare professional, and you're like, oh, I'm just kind of tight today, and they, use a Theragun on you or something, like that is by all means completely fine to do. Like we're not trying to monopolize this idea of like manual therapy and exercise, but I think there's a fine line between, like, I just need a little bit of work done because I have some soreness from some of the training I've done, versus I have a legit injury that needs special attention so it doesn't snowball into something much worse.
Right. And yeah, and going off of that, you got to be careful with what you call rehabilitations. Like if your personal trainer or strength coach is doing some hands-on work with you, maybe not hands-on, but like using a Theragun or Theracane,
Yeah.
you really can't call that rehabilitation. Like that's like an industry standard word, and it's definitely legally defensible, and that word should really only be used by a licensed healthcare professional who is licensed to practice rehabilitation. I don't know if you had anything you wanted to add to that.
That's a great point to bring up. That definitely slipped my mind. But yeah, I feel like the word rehab or like rehabilitate, it's got kind of watered down, you know? It's like using like stabilization or like activation. It's just become one of these like, you know, like catchy words that you can throw on social media or like if you're having a one-on-one conversation with someone, if you throw the word rehab or you throw the word stabilization, one of those catchy words into the conversation, it's almost used for people to be like, oh man, this person really knows what he's talking about, or she really knows what she's talking about. You know what I mean? Like it seems like more of this word to try and market versus actually like performing what that word means. And as you alluded to, legally in that sense. So yeah, no, I think you hit the nail on the head with that one, Christian. I think that's a really good way of putting it.
Yeah, and I think it's like I know that you're saying that these words get diluted, and I totally agree. But these words really do matter, especially in the context of scope of practice, because if you have someone who's not trained with these different diagnoses, let's say a personal trainer compared to a physical therapist doing quote unquote rehabilitation, if that personal trainer thinks that they can handle this because maybe they've seen it several times, they've read something about it, the the problem is that they don't know what they don't know. They may think it's
Hmm.
this one thing because that's like the only thing or only handful of things that they've read about. But there could be like dozens of potential things that are going on of various levels of severity. And it's
Hmm.
super important to recognize like a hallmark of someone who's really intelligent, I think, and self-aware is recognizing what you don't know and knowing when you need to refer. So like we do this every
Hmm.
single day. We see things, see patterns of pain from people that don't match up with the diagnoses that we are trained to handle. And if we see that stuff, we are trained to, but also legally obligated to refer you to someone who is trained in those things, such as in the context of orthopedics and sports, a sports medicine physician, or sending you back to your orthopedic surgeon if there might be a complication with your prosthesis or new ACL graft or whatever. We just recognize what we
Hmm.
don't know and then we refer to the appropriate person. That's a skill. It's an exercise in humility, and it's something that we all need to be doing. And just recognize that it's not like a slight on your ability, a slight on who you are as a person. It's just like there's just so much knowledge in these fields at this point that you really need to be careful with what you're doing.
To go off that point, real quick story I had about a month ago. This is completely true. Had a 60, less, I don't know, 62-year-old male come in the clinic, referred from pain management with low back pain, comes in, and he still had this history of low back pain, but he's starting to tell me that he's had a recent onset within the last week or two of this like really like sharp shooting pain that is not only going on the low back but also like up the side and like even like into his like lat area, and like it's just going up the back. And throughout the examination I'm like, this just, it doesn't seem muscular or like musculoskeletal in nature, right? Like we have things that we're looking for, and it's like this just doesn't make sense. You know, it's not responding to anything mechanical. You know, like all the tests are coming back showing that there's nothing positive. And so we're having the conversation. I tell him like, I think you might want to go to urgent care and like just get things checked out. There might be some other stuff going on here. Goes to urgent care, comes back the next week, and he had what was kind of the beginning stages of shingles occurring, and gave him what he needed to get better, and that pain went away. Now he still had some of that chronic low back pain that we've been treating, but like he was to the point of like he was just sitting in the chair and he's like uncomfortably like moving around, and like you could tell it just didn't seem normal. And so, yeah, referred him out to urgent care to go see a medical physician and came back and was like, yeah, I started having shingles, you know? And it's like that, like those are the types of things that as PTs we're trained to look for. And like you said, it's that humility factor of in that moment, I had to tell him, look, I don't know what's quite going on here, but it just doesn't seem right. And I think it could be something outside of muscles, bones, etc. And he was able to get it caught and worked on. But yeah, just to further that point, Christian, as PTs, we're trained in those areas to identify things of either quote red flag origin or just also um, things that just don't seem right and might not be musculoskeletal in nature, and they need someone else to take a look at it like a medical physician.
Yeah, I mean that's a perfect example of you using your knowledge of the different guidelines we have, which we'll get into next, but also just like that person not passing the sniff test. You've seen at this point in your
Yeah.
career hundreds, maybe thousands of people that have had this type of pain in that same kind of area, roughly in the same age group. You know generally how it plays out, not just from the research, but from doing it, getting those
Yeah.
reps in. And when something doesn't really add up, you're like, okay, that's just not passing the vibe check, time to move on, go to a different professional, let's just clear
Hmm.
the air here. Yeah. So
Yeah.
like you already kind of asked one of the questions I wanted to ask, which was, are physical therapists trained to look for scary stuff? And absolutely, we have extensive training. Is it super complex? No, but it's incredibly important. So there are a few things that there's a lot, but like a few that we'll touch on here. One, you mentioned are red flags. Another one are yellow flags. And then a third one for more specific stuff is like fracture guidelines. So what are red flags? It's anything that's potentially a sign of something very serious going on. So in the context of low back pain, for example, we have a few red flags, like you have a lot of lower leg weakness. Like all of a sudden your leg is crazy weak. Your foot's not working, it's dragging on the ground. Or you have what's called saddle anesthesia, where your groin is having numbness, tingling, or burning. That's not common. That's not normal. That could be a sign of something very serious going on. If you have a change in your bowel or bladder function, like you're constipated or you have incontinence, you're just going to pee all the time, not great. Unexplained weight loss, like you're losing weight and you don't mean to. Like people often like, oh, that's kind of cool, that's fun. It's like, no, that's not cool. At least not from my perspective. I get a little worked up about that
Yeah.
because
Yeah.
and I've seen these things. I've seen these things several times. I wouldn't say like a whole bunch. Thankfully, they're rare, but I've seen them several times where I've had to refer to doctors and it's come back with something very serious, like cancer is some I've seen, or like very emergent low back issues that need surgery like that week. And then the next one, which is less serious but can lead to long-term problems, which I would consider to be serious over the long-term health of this person. These are the yellow flags. Like you're looking for people that just have a negative relationship with their pain. And when that happens, they tend to have worse outcomes in the short term and the long term and can make it so they have a worsening disease process. They use a lot more healthcare than they should and just leads to them having like a worse life overall. This could be a lot of anxiety or a lot of depression that's not being treated or that's new since they had their condition. Those are probably the most common that we'll see. But then there's also other ones like fear avoidance. Someone is avoiding doing stuff like going to work, for example, because they're worried that they're going to make their problem worse. They're going to harm themselves by doing that. Or they have what's called kinesiophobia, where they just like they're worried about certain movements in particular. Like they just like don't want to raise their arm because their shoulder hurts and they're worried about breaking their arm or something. And then catastrophizing is a big one where people just don't really have context around what their pain is, how things are going to play out. And catastrophizing is just they take their minds to the worst possible place. They're like, this is awful. This is going to ruin my life forever. And that leads to a vicious cycle of like unhealthy thought processes around your condition, which we know all these different things I mentioned, all these things make your pain worse, make you recover slower, and make it so that you may not make a full recovery unless you address these issues. Then the last one I wanted to mention were fracture guidelines. We are trained And all physicians too are trained to use certain rule sets when trying to determine when someone needs imaging because you're worried about a fracture. There are the Canadian C-spine rules where there's certain criteria you have to reach to warrant getting a neck x-ray or more advanced imaging of your neck. There are the Ottawa rules. There's Ottawa ankle rules, Ottawa foot rules, Ottawa knee rules. These are just like little algorithms you go through that determine whether someone should get an x-ray because you might be worried about a fracture. And then there are also just like different, what they're called clinical prediction rules for determining whether someone needs imaging for certain cases. Like there are some in the elderly, like someone has a fall, they're this age. Do they check these other boxes? If so, we should get an image or we shouldn't. Anything that you
Hmm.
wanted to add to those things?
Yeah. Yeah, no, I'm absolutely. I think that's all really good information. And I also think, like, even like sports wise, right? Like we have clinical prediction rules for things like meniscus tear, or clinical prediction rules for things like rotator cuff. We have these different things also. Like it's not just like big scary, like did you fracture your C2 vertebrae or did you like do you have cancer, right? Obviously we want to catch those before anything else because those can be like life threatening, but even down to like the sports side of it too, like do, do you have a rotator cuff tear or do you just have like subacromial pain syndrome, or like do you have meniscus tear or do you just have like patellofemoral pain syndrome? Those different things like you mentioned, like the Ottawa rules for fracture and whatnot. So yeah, no, absolutely. And I don't know who in Ottawa just monopolized these fracture rules, but they must be making a lot on royalties with naming all these different rules after them. I don't know who they think they are,
Where the Canadians
but
just break their bones a lot more than the rest of the world.
right, yeah, it's all the bears they're fighting up there.
Something I wanted to get into, maybe this would be our last segment, would just be like, can physical therapists order imaging? Or really, who orders imaging? What are some of the thoughts around there? Did you have any thoughts around that to start, Eric?
Yeah. So at least I know in the state of Minnesota can't order imaging, and with physical therapists, honestly, what I tend to do is I look at again, do they meet the criteria for imaging? And then if so, I message their referring provider or I message like if they came from the ER, I message their primary care provider, give them an update, say, look, this might be worthwhile doing. So can we order imaging? No. Can we look at signs and symptoms and how you're doing and say, I think you should get imaging and then message the correct people about that? Yes. And in my experience, oftentimes the orthopedic or the referring provider or the primary care provider, like last week, I had a primary care provider, a medical doctor, tell me, like I was trying to explain stuff to her, and she told me, she goes, "Your world is completely different than mine, and so like I trust what you're saying." And it's like awesome. I think that they don't need an MRI, or I think they might need an X-ray, or whatever it is, and they're like, "Okay, great. You just tell me what you think, and I trust what you're gonna say, and I'll put in the order for it." So no, I can't be like, I'm going to get you in for an MRI tomorrow. But yes, we can contact your referring or medical physicians or PAs, et cetera, and have that conversation and, you know, maybe get you imaging now.
Yeah, I think that was a great example. It's also just like a shifting landscape where that did not used to be the case. People were pretty, or physicians were pretty protective over those abilities, but now they're like, look, just you know what you're doing, especially in the context of musculoskeletal health. Not really talking outside of that. They trust us to give them that feedback, whether it's going to be imaging or it's going to be whether someone could benefit from an injection, all that kind of stuff. And then
Mm-hmm.
going back to that CSM lecture I went to, they exposed me to an idea that I heard a while back, but I kind of forgot about, was that in the military, in the US military, physical therapists can order imaging and they can prescribe medications. Then I was like, okay, I want to look actually at the research there and see, do we suck at ordering imaging? For example, like, are we just like not as good at it as other doctors? And it turns out, compared to primary care physicians, again, these are more generalists. They're not like sports medicine physicians or orthopedic surgeons, for example. We tend to do a lot better at ordering images than those PCPs do, meaning that we order them more appropriately. So we're not ordering ones that didn't need to be ordered, for example. And in one study I read, they looked at the appropriateness of these images being ordered by PTs, and it came out that physical therapists ordered images appropriately 80% of the time. That's actually quite high. It was about 10% higher than the primary care physician studied in this example. And then I actually read a different study that was more of a trial where civilian physical therapists in the US got to order images at this one healthcare institution. And it was a 5-year retrospective study where like the physical therapists do the thing for 5 years and the researchers investigate all that data over the 5 years and look for what happened. And it turned out that, and this was from 2019, turned out that these physical therapists ordered images appropriately 91% of the time. That is like staggeringly good compared to the average appropriateness across all professions that can order. And so that just really goes to show that our training and understanding all these different guidelines and red flags and all this stuff sets us up to order imaging well. And even if we can't order images right now legally in most states, we know what to look for, when to talk to your doctor about when it's time to order that image. So like it really does work out. I do feel very strongly that physical therapists are highly trained and capable of understanding when it's time to order an image.
Yeah. No, I'm unfamiliar with those studies, and I think those results, that's awesome. 80, 90 some percent. That's terrific numbers. At least I think, taking it at face value. So no, that's awesome. Thanks for sharing that, Christian. Just one thing I wanted to touch on real quick was the role of, and this might not be quick, but the role of nutrition in physical therapy. I have a little tease here. I have a good friend who's a professor at my undergrad university who teaches nutrition, and I really want to get him on here at some point to discuss it, because I think he will do a great job of like setting the record straight and laying it out there. But there is, within the scope of practice for physical therapy on the APTA website, there is discussion around that physical therapists can provide simple, generalized, research-based nutrition advice for individuals in physical therapy. And when I say simple and generalized, it's very easy things, like make sure you're drinking enough water and eat your fruits and vegetables and just things like that. That's more commonplace, but we're not getting super in depth about like, you need to take this supplement of calcium 3 times a day because you need to raise your levels. And it's like, we're not going to do that as PTs, or we shouldn't be doing that. But we can do just very simple things like, how much water have you had? Are you eating a well-balanced diet? Are you taking in enough protein, right? Just like very simple things like that. I'm not sure if you have a different viewpoint on that, Christian, or you've read something else, but at least for me, that's how I interpret the Practice Act when it comes to nutrition and physical therapy.
No, I think that was great to bring up nutrition, because there probably are some therapists who might overstep there, but by and large, I think of it like we provide nutritional guidance about the same level as you would provide guidance for like a bodybuilder. You handle the macros, you got your proteins, your fats, your carbs, you got your water, maybe some like general supplementation like protein or creatine, for example. But we're not dealing with micronutrients. We're not dealing with giving nutritional recommendations for folks with certain diseases. And an example of this, and like kind of going back to staying in your lane, and just like recognizing that you don't know as much as you think you know. I have a patient who's a professional dietitian, and she works in the hospital in the pediatric unit. Her whole job is to create dietary plans for infants who are like on life support. That's what she does. And like these children might be intubated. There's all sorts of bad things. It's like, I wouldn't know what to do. I have zero training there, zero skill. Didn't even think about that thing being a thing till I met her. And I'm like, I am so glad that you are there, because if I ever need that service from a child, like, that's amazing that you have that skill set. and I'm so glad that that you're on our side.
Right. Yeah. Yeah. Exactly. Yep. And I think, like you said, stay in your lane is a good way to put it. And I'm going to steal something from my friend that I just brought up. Unless, and this was one of the first things that when I was taking his nutrition classes in undergrad, unless they have a PhD in nutrition or they're a dietitian. He's like, that's it. That's who, if you're going to be taking like nutritional, like in depth, like nutritional advice from, this is maybe a little bit beyond like, I haven't drank any water in 3 days. As a PT, I'm probably going to say, have some damn water, right? But if, if you're like, hey, how should I like, I want to improve like my immune support. What supplements should I be taking with certain foods? And it's like, unless they're a PhD in nutrition or a dietitian, like that too should be giving that advice. He even said like, he brought up like MDs. Nope. Strength coaches. Nope. Like, you know, chiropractors. Nope. Like dietitians, PhD in nutrition. That too should be giving you that dietetic advice.
I have this conversation a lot, and I guess I wouldn't call it a conversation. It's more like people ask me all the time, "Hey, should I like use turmeric or should I like drink cherry juice or what should I do about my diet to help this condition?" It might be like shoulder pain. And I'm like, I'm glad you're thinking about that stuff, but honestly, I cannot speak intelligently about the use of those things to help this condition. That'd be a question for a trained nutritionist or dietitian, not myself.
Yep.
That's how I answer it,
Yeah.
and and they're like, "Oh, okay, great, thanks," and we move on because I don't know.
Yep.
I have zero idea.
Yeah. Right. Yeah, absolutely. Yeah, exactly. So, no, I think a big takeaway for me on this podcast is number one is stay in your lane when it comes to different things, right? If that's what we talked about with rehab in the scope of practice, if it's ordering imaging or giving nutrition advice or medication advice, whatever it is, stay in your lane with what you've been trained to do. And if you want to, maybe discuss medication, or if you want to discuss nutrition, or if you're a non-rehab professional that wants to discuss someone's therapeutic exercise plan, and then you should have that discussion with that professional, respectfully, of course, and bring up to them, um, hey, how do you think this medication might be affecting this aspect of this patient? Or, you know, hey, like I think this patient could maybe benefit from more hip strengthening. What do you think about adding certain hip exercises? Things like that. I think that's my big takeaway is stay in your lane. And if you have something you want to discuss, respectfully discuss it with that trained healthcare professional.
Yeah, totally. I guess it's just we might edit this part out, but something that I think about a lot is like, especially in our current political climate and professional climate, there are a lot of people who post COVID have really questioned expertise and expert guidance, and they're like, do they really know what's best for me? And like, I'm all for being skeptical. I'm a huge skeptic myself, but I am also one to genuinely and honestly support expertise and trust it first. Of course, like look into it yourself to the best of your ability, but there are experts for a reason. And I just like to think about the old like engineer with the hammer parable. I don't know if you know about that one, where you are not paying someone to do the thing. You're paying someone to know what needs to be done, how to do the thing. You know, when the engineer has this broken thing they got to fix, they hit it with a hammer. You didn't pay them to hit the hammer or hit with the hammer. You paid for them to know where to hit with the hammer to make the thing work again. That's what we do. That's what we all do in our different lanes, and that's the best starting point.
Yep. Yep. I like it. Leave it in. I like that. I think that was good. No, I agree. I agree. It's good. It's okay to be skeptical, but yeah. Yeah, I think there's, I don't think we should quote throw the baby out with the bathwater. I like your parable about the engineer at the hammer, and I also think that it's true with, we shouldn't throw the baby out with the bathwater in terms of, if you've had a bad experience or you're unsure about trusting a certain profession or whatever that might be. Just because you've had one, it's okay to be skeptical, and it's good to do that and do your own research and find someone that you trust, right? Find a PT that you trust. Hopefully you and I. Find a medical physician that you trust. Find, a chiropractor that you trust. Find a strength coach that you trust. All these other things, like find someone that you trust and, take heed their professional and expertise advice on certain things. Yeah, that's all I got with that. So anyways, I think we honestly talked way more than I thought we would talk about
Way
when it
more.
came
I
to
didn't even
scope of
get to like
practice.
half the stuff I planned to talk about, but maybe that'll be part two.
Part two podcast will come out when we're talking about scope of practice. I know I wanted to get into medication and stuff too, but I think it was a great podcast discussing, at least just introducing the idea of scope of practice and then going over some more main ideas when it comes to things like PT and scope of practice. So no, I thought it was a great podcast, Christian. Any last minute things you wanted to add or anything else you want to discuss?
No, I'm good. We'll save it for part two.
Okay, perfect. Sounds good, man. Well, thanks everyone for listening. Hopefully you found something good from the podcast to take away. And if you have any questions or might have maybe more confusion after this, then hopefully not. But maybe you listen to it and you're like, wait a second. Feel free to reach out to either Christian or myself, and we'll be happy to discuss those things with you. Anyways, till next time, till part two. We'll talk to you guys later. Have a good one, Christian.